Hey everyone, welcome. Last day of SAEM. Great job. Shout out for being here at 11 o'clock on the last day. We appreciate your time and attention in this talk that's very passionate about feedback. So I'm Sree Natesan. I'm one of the APDs at Duke.
And I'm Gore. I'm one of the APDs at Rush in Chicago, Illinois.
Yep. And we're excited to talk to you about feedback under fire and really share with you an evidence-based approach to how to apply feedback in a very busy emergency department. And we have no disclosures.
So some of our objectives for today is we are going to try to make sure everyone leaves this room feeling a little bit better about how they can provide feedback to our learners, as well as maybe improving the culture of feedback in your institution and how to engage learners in reflecting on their own process of receiving feedback. So those are overall goals. But first, let's start off by talking a little bit about the barriers to giving good feedback. So I'm going to put this out to our massive group here. What do you feel like are some of the biggest challenges that you face on shift to giving good feedback? Confrontational, yeah. Time, yep.
Yep.
Yeah, so the setting in which you're doing it might not be ideal because it's a busy ER. Are you going to walk away and go have a breakfast? So this is what we came up with. I think some of the things that you all said kind of reflect very well on there. I think the busy environment is overall in the literature when it comes to feedback is one of the biggest things that we tend to talk about and try to figure out how do you mitigate this busy feedback situation or a busy environment situation. And we'll talk a little bit about some tools that you might use for that. And then the uncomfortable piece, right? Like it's not comfortable to give constructive feedback sometimes, and so we'll also try to address some tips and things that you can do to mitigate that.
And definitely don't feel like you're alone in this. That's why some of these words are very big, like even the concern for retaliation. At our shop, we don't give blinded feedback from the faculty to the residents. They know when we put something that's constructive, they'll know that it's us, right? And so that gets a little bit hard to know, like, how do you do that in a way that they won't feel attacked, right? Or they won't feel that we're out to get them and all of these things too. So we'll definitely talk about some strategies. So we had the talk kind of broken up into the three main components of feedback. So giving feedback, receiving feedback, and then we'll touch base just kind of briefly on the idea of feedback culture, because really, in order to get your faculty members involved and even your residents involved in receiving feedback, you really have to touch base on the feedback culture itself and making that the norm. So at the very end, we'll talk about that. And just as a little disclaimer, this is going to be interactive as well too. I like to make a safe environment, so just you can drink your coffee real quick and get ready for it. But we'll share some tips and strategies, but we'll have you practice giving feedback, and then we'll also work together about how to receive feedback, just so you can actually leave here practicing those tools, so you can apply it on your shift, which for most of us is probably tomorrow. So for giving feedback, these are the main kind of 6 tenets that we found in the literature that kind of, if we were doing like a qualitative analysis and pulling out themes, these were the main categories that we were finding about it. And we're actually going to walk through each one of these separately to kind of help us to understand it. I'll kick us off with self-reflection. So I'll ask you a question. So if you're asking your resident or your learner, how do you think that went? Do you think they're going to be, more easy on themselves or more harsh? Harsh, right? I actually love starting with self-reflection because they're like the worst critics, right? We're our worst enemies. Oftentimes is what we think about. But they're very hard on themselves. They actually sometimes get to be the cheerleader in the end of it, being like, actually, no, you should not quit medicine. You should not stop being an ER doctor, right? You actually did fine. And these are the concrete ways that we can talk about fixing it. So self-reflection is really a key way to kind of help you. This is also one of the important things, especially for helping residents receive feedback, which we'll touch base on in a little bit. But definitely self-reflection is a great way to start the conversation with feedback.
And feedback should be based on goals and expectations, and those are best assigned at the beginning of the shift. You can think about it from okay, let's work on something based on your milestones. But I feel like so many of our clinical faculty especially are just not super familiar with our milestones. So, getting a sense of what that resident is just working on is kind of the best place to start sometimes. So I always start my shift off asking them, hey, what are you working on? And most of the time I want to look at EKGs, or I want to be more efficient. And how do you get past that? That's like, I think that the bigger piece of getting really good feedback and goal-directed feedback to residents is actually asking them to be more self-reflective and push them a little harder when it comes to that initial question. So when somebody says, I want to work on EKGs, I'll be like, well, are you working on getting to know patterns of ischemia? Are you getting to know arrhythmias? Are you trying to get better at documenting those EKGs? What exactly are you working on? Or when it comes to efficiency, where do you feel like your biggest barriers are to becoming more efficient? Is it in your reassessment of patients? Is it in your documentation? What exactly are you working on today? And I feel like I'm much more successful at providing better feedback when I get that sense at the beginning of the shift and really push them. And so sometimes it's a matter of just spending that extra 3 minutes having that conversation.
And it's really key because otherwise they might not receive feedback in that same way. But if you know it's important to them and they know that you're watching them to give them feedback on it, now you have this bi-directional communication that we'll talk about more. And then based on observed behavior, this is really key as well too. So you can imagine that if someone told you about your behavior but they never actually saw you do that work, you're less likely to think that that's important. Similarly, when you're giving feedback, if you can actually watch the interaction happen, it can really be a lot more impactful for the learner because I saw you do this. The simplest way for me to do like this is actually I like to go into the rooms with my residents at least once a shift. Sometimes if we get 5 or 6 patients, put in the pod at the same time, I'll actually grab my senior resident because I know they have to pick up the bulk of that. And I was like, let's just do rounds together real quick. And I'll actually jump on the computer. I tell them I'm the scribe, so I'll actually do the HPI and the physical exam. I always leave the MDM for them to do because that's kind of where the processing and learning happens. But I can actually observe them, and they don't realize that they're like, oh, Sree's so nice. She's watching, doing my notes. But I'm actually observing them to be like, hey, do you see that patient's like body language change a little bit when you said this or that? So I can give some really direct feedback about what they did. The second part about like going into the room is actually doing their notes. Is for my own note, all I have to do is my medical decision making because all the rest is in the resident note. So that's a way for efficiency to kind of speed that up. So, and the other part with direct feedback is making sure it's timely. So you can imagine that if you had a situation that you need to give constructive feedback, waiting 2 or 3 weeks later to talk to your learner about it, they're not going to remember it. So really trying to be thoughtful about the timeliness of it can really make a big difference.
Feedback should also be very clear and specific as to the thing. And I think what Sree just said about going into the room and being able to observe them and then being able to point out very specific details about what they did. It should never be about the person's individual quirks. It should be about specific behaviors, right? So that's the big challenge in feedback. We want to try as much as possible to take away the subjective, oh, you're this kind of, you have these quirks as a human being, and really focus mostly on the objective things that we find, and it's clear and specific. The other piece to clear and specific is that, if a person comes to you and says, has a really disorganized presentation, their H&Ps all over the place, they don't include pertinent positives and negatives, if at the end of that you say you really need to get better at your presentation skills, that is not going to help that learner. So being as specific as possible about what about that presentation was bad is really important to their growth.
Anyone here ever just say like, good job today to your resident? I wince when I do that now because I'm like, oh, I know better, right? And so that's why that we specifically chose this because we're like, all of us will still do that, right? It's kind of still the nature of the culture that we were raised in is to just say good job. But really the specificity makes an important part and tying it into a plan. So an action plan where they can, if you say like your presentations for like the differential diagnosis, you gave me all the worst case scenarios, but you never told me like which ones you wanted to work up and which ones you actually rolled out. Next time I want you to prioritize that. That's a different conversation than just like good job or work on your differential diagnosis, right? They don't know what that means. So being a little bit more actionable about it. And also if you're able to kind of work with your resident and be like, on our next shifts, this is what would you like to see happen? Or tying it to their goals again and of how they want to grow, what kind of steps they want to do to meet that goal. And also just what kind of follow-up you're going to have with them, it can actually really help them to actually have those behavior changes that we're trying to see in the very quick 3 years of residency, 3 or 4 years of residency that they have.
And you want to really balance out how much corrective feedback you give them and how much reinforcing feedback you give them. So like the good and the bad feedback, right? We all are, it's so easy to be like, oh yeah, you did an awesome job. But it's also important to go back to the tenets of, it needs to be specific. What did they do an awesome job about, so that they know the next time to continue to do that. So when I give them feedback on something they did really well, I specifically say, you should do that again. And that kind of cues them into, okay, this is actually a piece of feedback that I should continue to do this particular behavior or particular action. And it's also really important to try to always find some little tidbit to give them a corrective feedback on. This becomes really important in our really superstar residents who seemingly are like, oh yeah, good job. Or it's important to find those little nuggets of, hey, this is how we would have maybe differed in our practice styles here. Not necessarily something that you have to change, but something you have to consider. And so I think it's really important to balance out those things, and especially in those learners that are either superstars or really struggling, because if you give too much of corrective versus too much of a reinforcing, you might perpetuate there's a word for it.
Yeah, either a misconception that they have, or like just propagate kind of the problems that they may have or not have as well too. And we actually had to incorporate this in our like MedHub evaluations itself. We found like all these great glowing, our faculty like to brag on the residents, right? But some of our residents had problems that needed to be on corrective action, right? And that's really challenging if you really have like very strong, like beautiful evaluations in MedHub and not enough supporting evidence to say actually they're struggling in the clinical realm and they actually do need more coaching and more help itself. And so we actually changed our MedHub evaluations that we have two different categories, and it's all comments. So you just either dictate it or type it. But it's like, what is something that the resident did well on shift, and then what is one area that they can improve on. So it actually calls us out that we have to choose to answer both of those questions. To be fair, people put smiley faces on the areas to correct, so they don't always fill it out still, or like a little period because it fills in that required action and they click submit. So people find the way around it, but at least we're trying to kind of educate them, because there still is that uncomfortableness about it, but it still is important. And that's why communication is so key to it. So if you're giving reinforced or constructive feedback to your resident, it really is important to do it verbally and then follow it up on like the MedHub evaluations as well too, so they can see it. If sometimes like I'm on a shift and we know at the end of our shifts it goes crazy, right? You never get out on time, and sometimes having this conversation is a little challenging. I will at least try to pull them aside to do like walking rounds and just talk with them a little bit if it's really something that needs to be addressed. Otherwise, a follow-up like email being like, this is what I put in your MedHub evaluation, right? Just to kind of decrease that activation energy, and then giving them my number to call and talk about it, or catch them on the next shift together. But communication is really key to talk about the areas of growth.
And I think that one of the things that when you go through residency, you're like, oh, I'm a good doctor, I feel good about those things. You never really are taught how to potentially give constructive feedback, or you never really taught how exactly to have those tough conversations sometimes. And so it's important to realize that this is a skill set. This is something you have to grow at. This is something you have to actually think about and practice. And so I love always like a good framework for something, because it helps me when I'm like going into that thing. It's kind of like the ABCs, right? You're going into a room and you're like, I got this because I got my ABCs. Well, similar to having these hard conversations, I always kind of go back to this model that I was introduced to by a psychiatry colleague of mine. And it's the advocacy inquiry model. And it's very simple. You start with an observation. You tell them, this is what I noticed. So this is also something you can use in your like real life when you're talking to like, say, a partner. My husband's right there, so I'm gonna pick on him and be like, honey, I noticed that the trash that's like the task that you're supposed to do has not been taken out in a week. I'm concerned that things are gonna start smelling. What is your perception of this? And I know that's a really stupid and silly example, but you can utilize this model in multiple ways. But if you kind of go back to this and frame it in this sense, I generally speaking have had better conversations with the learner that I'm having that conversation with. And it allows me not just to really frame, like understand their perspective, but also frame things. And so that framing piece is also really helpful to getting at knowledge gaps, or getting at what is your actual gap, and what milestone should I be working on you with, right? So we always sometimes are like, oh, that there's a gap in that residence, whatever, but how do I actually address that? And so that inquiry piece can help us address it. So say that this is a scenario where the resident tells the nurse to push succinylcholine before the patient receives etomidate, okay? And you're in the room and you're like, oh my God, no. And in the immediate setting, right, you're like, no, let's not do that. But then how do you approach that when you leave that room? And that inquiry piece can help you really figure out, what do I need to address, right? If the resident says, I thought the propofol was already running because I saw it hanging, is that a situational awareness issue? Or I thought succinylcholine was a sedative. That's a knowledge gap. Or I thought the etomidate was already in. Is that a nursing communication issue? Or the family was distracted and I couldn't hear, so is that a cognitive overload issue, right? So trying to parse out what exactly the gap is really aided by this conversation.
Yeah, and that's why it's really important, because you can imagine the feedback you give for each one of these frames would be very different to that learner, and the advice you give them, the action plan, is very different. So that's why it's really key. So we're going to go through just a few kind of feedback tools and techniques now, using that framework that we kind of laid of those key components. And then right after this, we have a scenario that you guys will be doing in pairs to kind of start practicing this together. So the 1-minute preceptor model, anyone hear about this? Right, this is actually the most studied actually within medicine itself, OB, internal medicine, and all the rest. Actually, this is the most common model used. But essentially, it has teaching and feedback together. So the first is getting a commitment. So usually when we talk to our residents, what do you think is going on? What do you think is happening? The second is probing for evidence. So why do you think this patient is having a PE, or why do you think they're having pneumonia? What did they tell you in the history and physical exam? Teaching general roles, you can talk about the heart score. You could talk about PERC criteria. You could talk about some of those little teaching tools that you want them, or even simple things like for PE, these are the questions that I like to ask. And then reinforcing what was done correctly. So this is where you can do the reinforcing feedback. So saying I really appreciate that you asked the worst case scenarios, but you forgot to ask about PE and this patient who just traveled, across the sea. And then the fifth is correcting errors, right? And so this is really where you can talk to them about how, and make it actionable and specific about what they can actually do better.
And a lot of these tools you'll find are kind of subsets of each other. And so if you can't remember the 5-minute preceptor, this one's a pretty easy one to remember. It's ask, tell, ask. And so it starts with really reinforcing the need for that self-reflection, right? So learner self-assessment, ask them how they think they did. And specifically ask them, what do you think you did well? What do you think you could improve on? And then have that conversation. The tell piece is you're going to have that conversation about, I agree that you did well here, and then here's another additional tidbit about what my thoughts are on, or what you could work on. And then ask them for a specific action plan, okay? So it always ends in asking them for them to, again, self-reflect and figure out how they're going to change for the next.
I know we're getting close to lunch. You guys hungry? Hungry for this type of sandwich? Right? So we call it the feedback sandwich. There's other words in our head that we also call this as well, too. This is a modified version of it, where they actually are trying to not make it be positive, negative, positive, right? Which is the way that our learners. The reason why this is actually, even though it's probably the most used, it's not the best for our learners, and also for us in giving feedback, is that our learners know that the negative's coming, so they don't even hear you as you're saying the positive comments, because they're bracing themselves, getting ready for it. And the problem is that they know you're going to follow up with something positive, so then it's not authentic. So that's why of all the ones that we're teaching you, this is probably the one that's not the best to use. Even though we start putting toppings on top of it, you can see, to kind of layer the sandwich to try to make it a little bit better, this is still probably the one that our learners will not receive the feedback as well.
Spikes is a model that started off in the palliative care world, and it's actually utilized to give really tough conversations with patients. But it has been utilized and modified for medical education. And it's very similar to the ask, tell, ask model, but it's broken down a little bit further so that you get a little bit more about what am I asking about? So setting up the expectations at the beginning are kind of thinking about how you're going to go into this. I use this more so when I have really tough conversations where I'm meeting the resident in the office and being like, okay, we're going to have this really a difficult chat. So kind of sometimes I rehearse this in my head, or I think about the special considerations for that particular resident and how they've received feedback in the past. And then perception, like asking them for their perception, inviting them to kind of add to that or ask questions about that, and then imparting your knowledge. And the one thing I do like about this model is that it includes emotion, and it acknowledges that this is an emotional thing that we're doing here. And so it leaves space for that. And, you know, it's how do you have that, you know, how do you feel about this conversation? You again, got to gauge your learner and kind of figure out what the right strategy for that is. And then strategy and summary, again, action plans, right?
And the ED stat was actually made for our kind of ED environment itself. You'll see that a lot of this kind of echoes itself. So even though you may not need to label kind of which framework you're using, you see a lot of this is kind of similar, like setting expectations, diagnosing your learner, like, you know, what are their goals, also what level of training are they in, so doing the setup and teaching them during that interaction, and then really assessing and giving feedback is important. And then also the last part I really appreciate about this one is being the role model to our learners itself, right? It's like modeling the behavior that you want them to actually learn itself. So now it's your turn to practice. So we're going to have you kind of like pair up, and luckily you guys are kind of similarly maybe in teams there. But one of you can be the learner, so you'll scan the QR code on the left, and the other one will be the instructor who will scan the QR code on the right. And for our learners, you're going to be just reading the script. There's a little bit of a caveat at the very top. Feel free to use your like Academy Award acting skills if you want to, but the script is right there. So you'll read it, and your instructor is going to give you feedback on that, okay? So we'll give you probably just a couple of minutes to run through that.